السلام عليكم. معلش بعد طول غياب بيجيكم راجع. هنتكلم الليلة عن Idiopathic pulmonary fibrosis. عندنا case scenario: a 57 years old lady present with worsening exertional dyspnea for 1 year associated with non-productive cough, fatigue and small joint arthralgia, and her medical drug and family histories are unremarkable. So main key features are 57 year, worsening exertional dyspnea, chronic non-productive cough, fatigue, joint pain, unremarkable family and past medical and drug histories, no smoking history or exposure to allergens. Her BMI is normal. Examination shows fine respiratory crackles and raised jugular venous pressure. Investigation: what we want to do for this patient, we want to do chest x-ray, which showed bilaterally diminished lung volumes, decreased lung volumes bilaterally, and basal reticulonodular opacities. Also, we will do high resolution CT, which showed in this patient bronchiectasis, which is dilation of the bronchi, honeycombing إشباخية النحل, and ground glass opacities. Also, we're gonna do pulmonary function test for the patient, which showed low residual volume, total lung capacity, low functional residual capacity, and diminished diffusion of carbon monoxide. So this is restrictive lung disease, and in the restrictive lung disease, it's a disease that affects the diffusion capacity of the lung. We'll do autoimmune screening, which is negative. So for a patient who presented with shortness of breath for 1 year, along with systemic manifestations like joint pain and fatigue, along with non-productive cough with unremarkable family history and exposure history, her examination by basal fine respiratory crackles and raised JVB, which indicate late manifestations of idiopathic pulmonary fibrosis. We will do chest x-ray, we will do high resolution CT, pulmonary function, and autoimmune screening. It's expected that you will find autoimmune screening negative or indicative of SLE or rheumatoid arthritis, and it's expected that you will find low lung volume in the chest x-ray and reticulonodular finding in the chest x-ray. It's expected that you will find honeycombing in the high resolution CT and restrictive pattern in the pulmonary function test. Okay, so how are we going to treat this patient? We're going to give her azathioprin, which is antimetabolite, it decreases immune responses, and N-acetylcysteine, which is a medication that increases our body store from cysteine, and eventually there is no way but lung transplantation if the patient is needing lung transplantation and is suitable for getting the transplant. So how we're going to reason this? You have to know that any patient presenting with shortness of breath have a differential diagnosis of heart failure, chronic obstructive airway disease, and interstitial lung disease. These are differential diagnoses for chronic progressive dyspnea. So when the patient says to you that I have shortness of breath, whether it is increasing, you ask whether it's increasing or decreasing or static. Increasing, so it's progressive. How long you for how long you are having this shortness of breath? So if it's for months and years, then it's chronic progressive. Differential diagnoses are chronic obstructive lung diseases, interstitial lung diseases, and heart failure. So we did chest x-ray, and it's suggestive of interstitial fibrosis with volume loss, while lung function test shows a restrictive pattern. These findings are supportive of interstitial lung disease. So lung function test showing restrictive pattern with chest x-ray showing interstitial lung fibrosis. This is a strong argument. We then did high resolution CT, also demonstrates fibrosis in patchy and predominantly bibasal and subpleural, while traction bronchiectasis and horicombin are present. So this is more likely to suggest idiopathic pulmonary fibrosis strongly. So the absence of orthopnea, paroxysmal nocturnal dyspnea, and angina, or a prior history of heart disease makes the absence of these factors makes heart failure less likely, because we said that the differential diagnosis for this patient is heart failure and obstructive lung diseases and restrictive lung disease. So the heart failure, we exclude the heart failure clinically by absence of orthopnea, paroxysmal nocturnal dyspnea, history of angina, or ischemic heart diseases. The heart failure will be less likely, while chronic obstructive airway diseases typically must be associated with exacerbations and remissions. It will never be steady or progressive shortness of breath. So the course of obstructive lung disease is over time. This is the course, this is the time. The course will not be like this, increasing. It will be like this. Actually, it will be more of like this. So it's exacerbations and remissions, and it is opposed to interstitial lung disease, which is usually associated with a slow but inexorably progressive history. And this is similar to our patient presentation in the case scenario. You have to also note that history of arthralgia, fatigue favors pulmonary pathology secondary to an autoimmune diseases. So what we have here, absence of symptoms suggesting of congestive heart failure, presence of history suggestive of autoimmune diseases, absence of exacerbations or remissions, and slow and progressive course of the disease. All these factors together makes the main differential diagnosis is interstitial lung disease. So moreover, the absence of joint swelling, joint deformities, morning stiffness, or extra articular manifestations makes rheumatoid arthritis unlikely, because we said the patient is having joint pain, arthralgia, but there is no joint swelling. Normal examination apart from bronchi and or tracheitis and raised JVB. So the absence of the deformities, morning stiffness, or extra-articular manifestation makes rheumatoid arthritis less likely, while no findings such as skin thickening, sclerodactyly, increase tension of the skin in the fingers, and telangiectasia, Renault phenomena, muscle weakness. All these may suggest scleroderma or other connective tissue disease. Also, the negative autoimmune screen exclude autoimmune disorders. So she has no history of organic and inorganic dust or environmental allergens. This makes pneumoconiosis and hypersensitivity pneumonitis unlikely, while the absence of bilateral hilar lymphadenopathy is against sarcoidosis. So chest X-ray showed no hilar lymphadenopathy. No hilar lymphadenopathy, sarcoidosis is less likely. So now we are left with idiopathic pulmonary fibrosis, and the patient have a finding in the high resolution CT that is associated with idiopathic pulmonary fibrosis, like sometimes the differentials are scleroderma and rheumatoid arthritis, granulomatous disease, and sarcoidosis, pneumoconiosis, and rarely subacute and chronic hypersensitivity pneumonitis. Why it's not scleroderma? There is no systemic manifestation of scleroderma in our patients. Why it's not autoimmune disease such as rheumatoid arthritis? No, it's not rheumatoid arthritis because joints are normal. There is no extrapulmonary manifestations. Why it's not granulomatous disease such as sarcoidosis? Because lymph nodes are normal and no hilar lymphadenopathies. Why it's not pneumoconiosis? Because there is no history of exposure to dust or occupational hazards. Why it's not hypersensitivity pneumonitis? Because there is no history of exposure to environmental hazards. So, in summary, the patient is seen to have interstitial lung disease with evidence of restrictive and impaired gas exchange. So, the CT finding strongly suggestive of idiopathic pulmonary fibrosis, as I said, while the clinical and biochemical findings and serology does not suggest any other cause. So CT, speaking about the CT scan, it's idiopathic pulmonary fibrosis. So we can establish diagnosis from here, and there is an evidence that if we combined azacitidine, prednisolone, and N-acetylcysteine, the benefits is off limit. There is no huge benefits of this combination, but however, the definitive treatment for these patients is lung transplantation. No need to administer IV antibiotics unless there is a suspicion of bacterial infection. Okay, so we can give them medications, but there is no evidence that they're gonna help. Patient will progress, so condition will deteriorate. So idiopathic pulmonary fibrosis is a chronic, progressive, irreversible, and usually lethal lung disease of unknown cause. This is the definition. Progressive, chronic, irreversible. 3 characters. It's chronic. It will present for months, years. It's progressive. It's increasing, not regressing or static. The patient is deteriorating, and it's irreversible. The patient will never become normal again, and the cause is unknown. So it's more predominant in males, and its frequencies increases with age. The patients typically present 5th to 6th decades. The pathogenesis is not completely understood. Current hypothesis is that a stimulus produces repeated episodes of lung injuries. There is a repeated episodes of lung injury because fibrosis is the net result of repeated inflammation or acute inflammation that turn to chronic inflammation. So repetitive lung injury resulting in activation of process associated with tissue repair. Tissue repair lead to fibrosis. For unclear reasons, this tissue repair occur in an aberrant fashion. It's overreactant the immune system and will lead to progressive, not a healing that occur in a, after after an injury as a response to it, and stop once the injury is out there. Or sometimes the injury or the stimulant may be present but we don't know about it. So the condition is progressive, and the patient typically present with exertional dyspnea and may be presenting with systemic symptoms. You have to know that the prominent systemic symptoms should raise the possibility of secondary diseases, secondary causes, not primary idiopathic pulmonary fibrosis. So the physical examination usually reveals, as in our patient, by basal inspiratory crackles. Sometimes we can find clubbing fingers in 50% of patients because they have hypoxia, and hypoxia lead to increased platelet drive growth factor, and platelet drive growth factor will lead to angiogenesis in the nail beds. So this is increase the nail bed space and increase its vascularity. With severe diseases, sometimes called pulmonary, may occur, and in our patients it was evident by raised JVB. A detailed occupational history may show exposure to asbestos, silica, as we said in the lecture of restrictive lung diseases, respiratory toxins. Sometimes restrictive lung disease may present with pulmonary fibrosis, massive progressive pulmonary fibrosis, and in addition, frank findings of connective tissue disease like rash, like joint deformities, like SLE findings will be present. So how we diagnose the patient? Up to 30% of patients shown any specific laboratory findings, and you have to be careful, and you have to note that the absence of supportive clinical findings and the presence of antibody alone does not imply an underlying autoimmune or connective tissue disease. Okay, so 30% of patients shows non-specific findings like anemia, elevated ESR, C-reactive protein, and increase in rheumatoid factor and antibodies. Lung function tests will reveal a restrictive pattern in the setting of idiopathic pulmonary fibrosis because patients will have restrictive lung diseases, and the total lung capacity will be reduced, functional residual capacity will be reduced, and the residual volume will be reduced. You have to note that the diffusion capacity of the lung will be reduced, indicating impaired gas exchange secondary to thickening of the alveolar capillary barrier. Clear? Then we do chest X-ray for the patient after the patient is presenting with shortness of breath, chronic shortness of breath, progressive bibasilar crackles finding, features of core pulmonary, increased JVB, and palpable second heart sound. We do chest X-ray which may show bilateral reticulonodular shadows which are predominantly localized to the lung peripheries. So we find the findings for pulmonary fibrosis are found in the lung peripheries and the bases. In addition, you have to know that the progressive fibrosis leads to cystic dilation of the distal airways, and this is called bronchiectasis. The fibrosis will cause dilation of the distal airways. So if this is the alveoli and this is another alveoli, they are connected together here. So cystic dilation of the distal airways, because fibrosis will affect the capillary barrier here, and it will affect the tension inside the alveoli, and it will cause cystic dilation of the alveoli, distal airways, and this will appear in the high resolution CT as if we created a black background like this, as if this is a lung in the CT scan. You will find that the airways will be dilated like this, as we viewed CT scans in the previous lecture. I don't know if you remember, all of you guys. So this is a chest X-ray finding, and in addition you can find the bronchiectasis in CT scan. You have to be careful, you have to focus, and you have to note that pleural effusions, air bronchogram, and hilar enlargement on the chest X-ray suggest an alternative diagnosis. So when you are doing a chest X-ray for a patient who is having a progressive shortness of breath, and when do you think of another diagnosis apart from idiopathic pulmonary fibrosis, is when you find pleural effusion, air bronchogram, air in the bronchi, around the bronchi, and a hilar enlargement on the chest X-ray. So hilar enlargement in the chest X-ray suggests, of course, sarcoidosis, and when you do high resolution CT, you will find a peripheral reticular abnormalities, which is sometimes intraalveolar, irregular, and sometimes subpleural. And sometimes you will find honeycombing and traction bronchiectasis, as we said previously. So these are suggestive findings and supportive findings in the CT. Patchy reticular abnormalities in the periphery or the bases, sometimes intraalveolar, inside the loops of the lung, linear, and sometimes it's irregular, and sometimes it's subpleural. Honeycombing and traction bronchiectasis. They are most prominent in the lower zone of the lung or the peripheries. So in the beginning of this century, in the year 2000, the American Thoracic Society and the European Respiratory Society said that the diagnosis for idiopathic pulmonary fibrosis must be done in the setting of suggestive clinical findings and high resolution CT findings, and must be as well as a supportive lung biopsy or bronchoalveolar lavage to establish the diagnosis. So you need biopsy along with clinical findings and high resolution CT. In 2011, American Thoracic Society guidelines removed the requirement for lung biopsy and bronchoalveolar lavage, and new studies shown that high resolution CT is highly specific. And when we say specific, we mean that when it's positive, it means that this is the disease. When the findings in the high resolution CT are, as we said just previously, reticular opacities and traction bronchiectasis, this is very specific for idiopathic pulmonary fibrosis. They are basognomic. When we say basognomic, it means when it's present, it indicates this disease. When this finding is present, it indicates this disease. However, I have to note that if clinical and radiological data is uncertain, you have to do biopsy and bronchoalveolar lavage for the patient. Why we do bronchoalveolar lavage for patients with idiopathic pulmonary fibrosis? Idiopathic pulmonary fibrosis is a diagnosis of exclusion after we have a typical clinical scenario, and we have a suggestive chest X-ray and a specific CT scan Then we sometimes we need to exclude other diseases like sarcoidosis, granulomatous diseases. So we don't do bronchoalveolar lavage unless we are suggesting sarcoidosis. For example, a patient with higher lymphadenopathy, or suggesting other granulomatous diseases. Okay. The most finding in idiopathic pulmonary fibrosis is only neutrophilia and or eosinophilia. So if you are doing bronchoalveolar lavage to diagnose idiopathic pulmonary fibrosis, we will find neutrophilia and eosinophilia, and they can be caused by anything. They are non-specific. So it means nothing actually to diagnose idiopathic pulmonary fibrosis, but it means something to exclude other diseases. So lung biopsy allows definitive diagnosis of idiopathic pulmonary fibrosis, but we don't need it unless there is uncertainty about the diagnosis with the clinical findings and high resolution CT. Tissue specimen need to be sufficient size to allow analysis of the lung architecture. So sometimes it necessitates an opening thoracotomy or video assisted thoracoscopic surgery. Tissue specimen obtained via transbronchial biopsy sometimes are inadequate. Okay, so the medical therapy for patients with idiopathic pulmonary fibrosis currently it's very ineffective, and when it's effective, it's poorly effective at its best. So combination of N-acetylcysteine, this is a medication, N-acetylcysteine. So it's a precursor of cysteine. Cysteine is amino acid, and when you give the patient N-acetylcysteine, it enters the body and it's donate cysteine to the body, and the cysteine is needed in synthesizing structures that balance free radicals, so it fights free radicals. Prednisolone, azathioprine. We combine N-acetylcysteine with prednisolone and azathioprine. It showed that there is a reduction in the rate of the decline in forced vital capacity and the diffusion lung capacity of the CO2 or carbon monoxide, but sometimes their clinical significance are uncertain. Other immunosuppressants, cytotoxic agents can be used, but no success have been recorded. You have to note that all patients who are diagnosed with idiopathic fibrosis should be enrolled on ongoing high quality clinical trials to detect treatments, to understand pathophysiology and so on. Lung transplantation is the only therapy that prolongs survival. Post transplantation 5-year survival is only 44 yet. So this is a devastating disease. Unfortunately, many patients are referred too late and die before receiving a transplant. So these patients must be referred early at initial diagnosis. So the complications associated with idiopathic pulmonary fibrosis will be respiratory tract infections, because there is loss of defensive functions of the immune cells in the respiratory tract. Pulmonary hypertension and cor pulmonare, because when you increase the thickness of the capillary alveoli barrier, you increase the alveolar size and you compress the capillaries and you increase the resistance in the lung. Also, the reduction in the lung volume increase the resistance of the lung. So vascular resistance in the lung, as we said in the first lecture, it's associated with lung volume. If the lung volume is too high, the resistance will be high. If the lung volume is too low, the resistance will be high. So it's lowest at functional residual capacity. So increased pulmonary resistance will lead to increased back pressure to the heart and causing pulmonary hypertension and or pulmonary. And bronchogenic cancer may also occur in patients with idiopathic pulmonary fibrosis, and the median survival without lung transplantation is less than 3 years. And the main cause of this is respiratory failure and infection. So in a nutshell, the summary of our lecture: you have to know that idiopathic pulmonary fibrosis is a form of interstitial lung disease which present insidiously and is often misdiagnosed. Patients typically present with chronic dyspnea and an unproductive cough and have fine bibasal respiratory crackles on auscultation. Clubbing is only present in half of the patient. So, idiopathic pulmonary fibrosis is a form of interstitial lung disease. It's often misdiagnosed. You have to know the presentation: dyspnea, cough, bibasal and respiratory crackles, clubbing. You have to understand that the findings may mimic other disorders like autoimmune disease, connective tissue disease, pneumoconiosis, and granulomatous disorders. Granulomatous disorders like sarcoidosis, autoimmune disease like pulmonary manifestation of rheumatoid arthritis, connective tissue disease like SLE, connective tissue disease like rheumatoid arthritis, autoimmune disease like SLE, and pneumoconiosis like asbestosis, for example. The presence of clinical findings plus high-resolution CT scan and the absence of any findings suggestive of other disease is sufficient to diagnose idiopathic pulmonary fibrosis. If there is a finding that suggests another disease, we may do bronchoalveolar lavage or lung biopsy. So if the patient clinical radiological result is uncertain, sometimes we may need bronchoalveolar lavage or lung biopsy. Medical management is limited, and lung transplantation is the only definitive therapy.